Chandra, will you let us know when a critical mass is on?
Yes, one moment. I think we're just having some technical difficulties over here, but we should be able to start shortly. Thank you.
Terrific.
Now we can see them.
Ready to start when you are.
Great. Thank you, Chandra. Good afternoon, everyone. I'm Jillian Gilchrist, co-chair of the Human Services Committee. My apologies for not being there in person. I will own I truly thought this was completely on Zoom. I did not look at the agenda fully. So happy to have everyone both in person and virtually today. And just really happy seems an odd word, but happy to be starting this work. This is very important work. When this issue got brought to our committee, the senator and I knew we wanted to take action. I want to recognize Representative Rader, who has joined us today, who elevated this issue. And so just really looking forward to the conversation and how we can make some positive change here in the state. And with that, I'll turn it over to Senator Lesser.
Thank you, Madam Chair, and thank you to all of you for your service on this task force. As
Oh, I think he is frozen. Let's give him a second.
But also some of the challenges with the Katie Beckett waiver program, given its long waiting list. So I think we should look at this task force as an opportunity to take a deeper dive into the Katie Beckett waiver program, to understand how other states are doing things, and also to lean in on, I think, important questions of medical ethics. When we have a limited financial resources, how can we best target the dollars that we have to support the greatest number of people or those most in need? What's the best way to spend our scarce resources to support kids who are in enormous need? And so it was a big, complicated question. I'm frustrated we didn't get further during the regular legislative session, but I'm hopeful with some smart people around the table who know a lot that we're going to make some real headway here in the off session. It'll serve us well heading into the next legislative session, which begins in January. And with that, Madam Chair, I'll pass it back to you.
Great. Thank you, Senator. I'm going to ask Chandra to, and thank her, first of all, for all of her help in getting this set up. It does appear that CTN is potentially having some camera troubles. Chandra, would folks still be able to introduce themselves who are in the room?
Certainly.
Okay, would you please do that and let me know when everyone has introduced themselves?
Okay. We'll just start with Mr. Negron. Would you like to go first? And we'll go in the circle.
Hi, all. My name is David Negron. I am the parent of a daughter with a terminal illness called Tay-Sachs disease. I'm just happy to be part of this panel to hopefully continue this conversation and ensure that we're meeting the needs of families with complex healthcare needs.
Hi, I'm Leslie Bennett. I'm the parent of a child born with a rare inborn error of metabolism and the co-chair of the Rare Disease Advisory Council.
Hi, I'm Molly Cole, and my daughter was actually the first child in the state that went on this program back in 1982. We didn't have a waiver. We kind of weathered through the whole application process. I'm pretty familiar with the differences in other states because I worked very closely with Julie Beckett on bringing this to other states and kind of really looking at the differences in waivers. So I am thrilled that we're finally doing this because this waiting list has gone on for decades, and getting people to really understand the importance of this kind of support to families such as ours, such as these, is really critical. So I'm thrilled.
Hi, I'm Louisa Kelsner. I am a pediatric neurologist and a geneticist at Connecticut Children's. And in that context, take care of many kids with genetic and other kind of chronic neurologic disease primarily. So I've spent years, I guess, often taking care of people over many years, seeing the struggles they have to take care of kids, obviously, at home. So happy to participate and learn more myself also, and hopefully add something to this issue.
Hi, my name is Beth Freza. I'm happy to be part of this work group. I have a daughter with a rare genetic disorder called pontocerebellar hypoplasia, terminal illness. We were on the Katie Beckett waiver. We first found out about it when she was 2. She was put on it when she was 5. We found out through a friend. So part of the reason why I'm excited to be here is to make some general awareness out there for parents who don't necessarily fit into a category that is well known throughout the medical community, for people who may be over income, may not have the ability to access those services that we need so much for our children who have complex medical impairments. And I'm very excited to be here. So thank you.
Hi, my name is Christine Weston. I'm the Director of Community Options at the Department of Social Services, and that's the division that oversees the home and community-based services, including waivers. And so essentially the Katie Beckett waiver administration and coordination with CMS falls under my purview. So happy to be here and to hear the feedback and the ideas.
Good afternoon, Nick Venditto. I am the designee from the Office of Policy and Management. I work as a principal budget specialist at OPM, overseeing DSS, and recently joined OPM. And prior to that was the chief financial officer for the Department of Social Services, who oversees the Katie Beckett waiver.
That's everyone in the room.
Great, thank you. Jennifer, would you like to introduce yourself?
Sure. I'm Jennifer Hand. I'm the mother of a 7-year-old little boy who has Duchenne muscular dystrophy. That's a condition that's most well known for putting kids in wheelchairs by their teens, but it also comes with a host of neurocognitive issues. So care of these children is extremely involved and requires a lot of resources. We've been on the waiting list for 4 years, which we got on right after his diagnosis in 2020. So I'm happy to be here to hopefully improve things for families like mine.
Great, thank you. Dr. Jermaine Lee.
Yes, thank you for having me. I'm Emily Germain Lee. I'm a physician scientist at UConn and Connecticut Children's. I see patients with all sorts of rare disorders within endocrinology and bone. I'm a pediatric endocrinologist, and I also serve on the Rare Disease Advisory Council with Leslie. I'm one of the physician representatives. Thank you for having me.
Thank you. Sarah?
Hi, I'm Sarah Macwicki. I am a master's student at UConn, studying social work, policy, and I am an intern for Representative Gilchrist.
Thank you. Dominic?
Hi, I'm Dominic Cotton. I'm actually not on this committee. I'm just a member of the public, but I've been working with waivers and rare disease for the past 25 years. So just happy to give my input.
Wonderful. And Representative Rader?
Hi, everyone. For those who don't know me, I am Representative Moira Rader. I represent the towns of Guilford and Branford. And this issue was first brought to me by David Negron and his wife, Rennie, about their daughter, Chloe. And David's with us on this working group. And I'm just so thankful to the co-chairs of this committee for at least getting us to this point where we have this group where we can, like they said, dig into this issue, because clearly there are a lot of families that we could be helping. And I hope that we get some really great ideas and answers out of this working group. So thank you for letting me be a part of it.
Thank you. And thank you everyone for being here today and participating. We thought it would be helpful to make sure we're all on the same page. So I want to review what our charge is according to state statute. So I'm just going to read from the Public Act that the working group shall, 1, develop a strategy to eliminate the waiting list for services and an alternate strategy to reduce the waiting list with estimated state costs. 2, develop a model for how the Department of Social Services could track children and young adults on the waiting list by type of disease or disability and life expectancy. 3, estimate costs to implement such tracking model and amount of time needed to implement such model. 4, recommend statutory definitions of terminal illness, limited life expectancy, and other terms deemed appropriate for use by the working group in the establishment of any priority tier on the waiting list for services in the waiver program. 5, determine average life expectancy associated with certain rare diseases and extremely rare diseases. 6, analyze models in other states for offering similar services to those offered by the Katie Beckett Waiver Program. Determine whether and how other states establish priority placements for such services, and estimate cost to adopt any such models or priority placement programs in this state. 7, determine to what extent the waiver program is serving all eligible persons in the state and, if necessary, develop a public awareness strategy to increase participation to the estimated capacity of the program in the future. And 8, develop protocols to ensure the protection of private health information of participants in the waiver program and those on the waiting list for such program in accordance with state and federal law. And we are asked that we submit our recommendations no later than February 15th of 2025. I will pause there to see if there's any initial feedback, thoughts, or discussion on our charge as a working group. And Chandra, if you can just help me with folks in the room, that'd be great.
Don't see any questions in the room.
I have a question.
Yes.
Given that outline of what we're tasked to do, is there any room for input on how it actually is working for families? I'm aware of at least one family in the state, a friend of mine who's had a lot of struggles in actually getting services covered and, reasonable access to like the resources that she needs. So I'm just not sure if that's a charge or can be worked into this work.
I think that's a great point and is something we should certainly look at within the conversation of how we could potentially change or expand. It would be helpful to know what's not working currently.
Okay, great. I guess a follow on, is there any room for additional members?
I'm always open to having more folks join. It's just, I believe how this works is when we do make our final recommendations, it's only appointed members who get to vote on the recommendations. Senator, what is your thought?
Yeah, no, I think I think we have a lot of expertise on the call, but I think bringing in additional expertise could be helpful. And I mentioned in my opening remarks, there are a couple of directions I think our charge could go in. One would be recommending that the legislature provide an additional appropriation. I certainly support that. I think we should, fund every kid who needs help. But knowing that there are a lot of claims on appropriations and we may not be able to get all the money that we need, I think there's another part of the charge that we've been given by the legislature is to figure out, are there better ways to administer the program that we have? And so, bringing in extra expertise to help us figure that out could be helpful. So I think the folks on the call or on the Zoom and in the meeting are extremely helpful. But one idea that I had was enlisting the services of a medical ethicist, for example, as another tool at our disposal. So there may be additional people who we could, tap in for their expertise in other fields as well.
Hi, Leslie Bennett. Would it be okay to maybe have public comment sections in our agenda so that we can have people from the public come and say something or tell us, what their needs are? That might help rather than expanding the number of people on this work group.
I think that's a great idea too.
Yeah, I think that's a great idea.
Yeah, that sounds fantastic. Okay, wonderful. Well, we thought today to kick us off, so we can actually get some work done in this first meeting, that we'd have a presentation from the Department of Social Services on the Katie Beckett Waiver Program itself. And then as you see on the agenda, we also received, and I hope you got it, sorry for the late arrival this morning, but information from the Council of State Governments on what's being done in other states. And then we do have time to discuss some potential topics for future meetings. So with that, I will turn it over to the Department of Social Services for their presentation.
Hi, hello. I'm inviting up Paul Chase, who is a public assistant consultant at the Department of Social Services and has been working in the Home and Community-Based Services Unit and with the Katie Beckett waiver for years, maybe a decade. How long? Long time. So very much our subject matter expert on these services and all things HCBS with me. So we'll be tag teaming this presentation. We decided to keep it brief, but added an appendix of additional details because, with the Katie Beckett waiver, which we'll see is, it also is an access to state plan services and other information. So we wanted the deck to have all the information, but maybe not walk through all of it right now. So do you want to go to the next slide, please? Okay, so just a brief overview for everyone who kind of doesn't live in the Medicaid space. Medicaid offers long-term services and supports through a variety of mechanisms, right? So we have what's called long-term care, which is an institutional setting, like you would think hospital, nursing home, sort of a skilled facility, and then what we call home and community-based services, HCBS. And those come under state plan and they come under waivers. So to further break that down, a state plan service is offered to all eligible members that would otherwise be eligible for what we call Husky. They cannot have a wait list and they cannot be geographically limited. State plan is open to all. A waiver service waives, use my air quotes, certain Medicaid requirements. It allows for services to be limited to available slots and with a wait list. Higher income limits than standard Medicaid can be implemented, and unique services and supports that aren't typically available to everyone under Medicaid could be offered under a waiver. So that's really just a helpful kind of level set distinction between how Medicaid offers their long-term services and supports. So we can go to the next slide. So the state plan services is our standard home health benefit, right? So that's when you think of a nurse coming into the home, PT, OT, speech that can come in. These are ordered by doctors, skilled nursing, and home health aides. So that's a home health benefit, and that's a state plan service. And then we have what's called Community First Choice, which is being utilized more and more by families that are on the Katie Beckett waiver. And Community First Choice is is a program for people that would otherwise be at institutional level of care to have in-home supports, but not have the waiver. So you have to be able to meet the standard Medicaid income limits. You have access to all of the state plan services, and then you get also access to personal care attendants called PCAs. So we're seeing a lot of individuals that were children and family that were on the Katie Beckett waiver now getting access to Community First Choice, which is a great thing, right? Because it kind of expands their access to a different array of services that they didn't have access to before. So next slide. And this is where we're going to turn it over to Paul. So in advance of the workshop, some questions were raised in advance, kind of for us to help kind of level set and provide some background about the Katie Beckett waiver, the wait list, who we serve, how we serve, and some general information. So we really just kept it at the question level and answered the questions. So we could kind of just tick through this for you. So Paul.
Yeah, so I'm sorry.
Say who you are.
Oh, hi, I'm Paul Chase, so the Department of Social Services. I work in the Community Options Unit. And I have been working with the Katie Beckett waiver for, as Christine mentioned, over a decade. I've spoken to hundreds of Katie Beckett families over the years. So what I'm going to do here is just kind of give a little overview of what the waiver is. And Katie Beckett really is probably our most unique 1915C waiver. The state of Connecticut operates 10 different 1915C waivers that are for different target populations. And Katie Beckett is the most unique in that really the intent of the waiver is not to provide a whole plethora of different waiver services, but to just provide access to the Medicaid state plan for its participants. So it provides access to Medicaid for medically fragile individuals up to the age of 21 would otherwise qualify for Medicaid based on the resources of their parents. So in Connecticut on Husky, if you're under the age of 18, 21 in some circumstances, you can only qualify for Medicaid if the resources of your parents qualify you for the program. So with Katie Beckett, eligibility is based solely on the income and the assets of the participant child. There's only one unique waiver service. So Katie Beckett has one waiver service, and it's nursing case management. And really what that constitutes for many of its participants is just a like twice a year, you have to have an assessment or a reassessment to determine that you remain clinically eligible for the program. And there is necessarily no ongoing waiver services that's being provided. So the waiver is providing you access to the Medicaid state plan and all the services that provides. And Christine did a level setting of what the HCBS services were available through the state plan. So that's the services that participants are accessing. Currently, there's a maximum of 342 participants on the program. We have 328 that are actively receiving services now. There's 319 on the wait list, and then there's 14 currently pending eligibility. So people that have been given spots, but they're not yet on the program because they're either waiting for a clinical assessment or their financial Medicaid eligibility to be determined. What questions are most common on the waiting list? It's incurable genetic syndromes and neuromuscular involvement. Cerebral palsy is another. We were asked what system is being used to manage the waitlist. So DSS developed an internal app to manage the waitlist for the Katie Beckett program. We also maintain hard copies of all the paperwork that is submitted to us for applicants and participants on the program. You can go to the next slide. How many people apply for Katie Beckett each month? Approximately 6 individuals. It obviously varies from month to month. The program, spots are offered when spots become available. When somebody comes off the program is when we can offer the next spot. So we average it out about 6. We looked at the last year plus statistics, and it's about 6 a month. How many people are on the waiting list each year? So we gave the January stats just to give you an idea that the wait list numbers have been pretty steady, meaning that the wait list time has not come down a whole lot, if any, over this period of time. This goes back to 2020, right before the pandemic. And then currently there's 323 on the wait list. And then the average cost for Katie Beckett participant We gave two costs. The average total Medicaid expenditure in 2023 was just over $54,000 per participant. So that's for all Medicaid services. And the average total waiver service expenditure, as you see, is only $218 because, again, there's only that one waiver service. It's that nursing case management, which really constitutes a reassessment twice a year. So that's the total cost of the program. You want to take the next?
So that really kind of was our overarching presentation, and I welcome you to kind of tick through the appendix if you guys have any questions. There's contact information at the end of the deck. And I think Ms. Hand, you had mentioned someone that is on services that might have a question. Paul, my information is at the end of the deck. We can get Paul's information out, and we'd be happy to take questions through our email if anyone has specific stuff, or if we wanted to start raising additional questions for DSS to answer. For the next working group, we can collect those two and modify the presentation for a next stage. But that is the DSS deck for right now.
And, Christine and Paul, do you mind if I just ask one question? How many of the people on the waiver right now are active? I mean, really use it? Because when you spoke to the Rare Disease Advisory Council, you said there were people that are on the waiver, but saving it for catastrophic events.
That is the case. In my experience, this is just my day-to-day anecdotal experience. I don't have the data right now to confirm that, but I know that there are a lot of individuals that state that they keep the Medicaid as a catastrophic backup because they have private insurance, but they're not necessarily utilizing it on a daily, monthly basis. And some that don't use it at all. So those are definitely important numbers to get. We will do so.
Because that would be very useful for us when we're looking at all of this, because we've got a number of people on the waiting list, especially in the rare disease community, when you're talking about rare genetic disorders and neurologic disorders. A lot of these are progressive, and our patients don't live for 5 years. So it's imperative that we get them on some sort of waiver because families are going bankrupt. The financial expense of caring for these children is just astronomical, and the physical toll it takes on families is huge. So if we could get that data, that would be very useful. Thank you.
I have a question. If you could go back to that last slide, I'm confused by the 50,000 and then the nursing home cost. What could you speak to that?
Yep. So so on the last slide, that goes back to the distinction of the ways we define Medicaid LTSS. So there's Medicaid state plan. That's just typical Husky coverage. And then there's the additional supports and services that can come with the waiver. So typically the Medicaid spend per child is $54,000. And that's doctors, pharmacy, events, shared third-party liability with their own private insurance. And then the waiver spend is simply that case management cost, because there are, as we were saying, there's no menu of waiver services for someone on the Katie Beckett waiver. It is simply access to Medicaid. We are waiving the parent's income. That is what we waive. And we allow the child to be considered independently of their parent's income to qualify, which opens up state plan.
I have a follow-up question to that. Can you clarify whether that is the full state share, or does federal government reimburse a component of that?
The 54,000 would be the full gross amount. There is a match in Connecticut. The base federal match rate is 50%.
50%. So the state cost would be 27,000 per child.
Yeah, approximately.
Thank you.
And just one comment on all of that is that the cost share issue is a really significant one in this Katie Beckett waiver program, because a lot of the families do have insurance that picks up some of what their costs are. So, as you just mentioned, so you've got the feds sharing cost, then you've got the families and their private insurance sharing costs, and often sharing some of the care, which we certainly did with my child. We had a need for an enormous amount of skilled nursing, but we did some of the care ourselves. So translating all of that out, these kiddos that are really complex, that need a lot of care, are getting the benefit of a lot of cost sharing, which is why it's always stymied me that we never wanted to do more with the waiver in the first place, because it just makes sense.
Can I make a follow-up comment / question? To that point, is the 50, am I understanding correctly that the 54,000 is average across Medicaid, across the children waiver or not?
No, so what was our total? 300? Hold on, I'm going back to the total. So of the 300, bad eyes, the 328 active individuals on the Katie Beckett waiver, if we average all of their Medicaid spend, so some of them could have 200,000 and some could have $218, right, over the year. The average over the 328 is 54,000.
Okay, so it is specific to the waiver children.
It is
Okay.
just specific to those children. Yeah.
Okay, thank you.
So how long have, on average, does a child wait on the waiting list prior to being accepted into the program?
So it fluctuates. Right now, I believe our applications are in April of 2019 or around 2019. So if a child had applied when they were 1 or 2, back in 2019, they will likely be reached as they get reached on the list. And as Paul mentioned, it's through attrition. So we don't add slots. We, as one person ages off or comes off the program, we put another child on.
So if it's 2019, based on, my limited arithmetic skills, that's 5 years is approximate the wait list time.
Yes.
I'm just going to ask a question about the eligibility criteria. Is there anything more specific about it? It's sort of institutional level care. Then there's some mention of terminal conditions. I don't know if there's something more specific. And also if there's any, it sounds like the wait list is just based on when you're put on. It doesn't consider need.
So that's very true. So we are a first come, first serve in how we manage all of our HCBS wait lists in DSS. So we take application date and then you're reached to start the process to apply. For most individuals haven't already been on Medicaid if they need to apply for Medicaid. In the appendix, there's a little further detail on each of the waivers. So the eligibility requirements for Katie Beckett is defined as children in the community under the age of 22 with significant needs that would otherwise require institutional care. And then the institutional care is the slide, sorry, above it, which might have been out of order, but that's really just, it's a level of supervision and cueing for activities of daily living, which consist of bathing, dressing, toileting, eating, and transferring. It could also be a cognitive impairment, which requires daily supervision to prevent harm. It's a pretty broad definition. It supports medical necessity. It really is like, would you otherwise, absent services, likely need to be in a skilled facility to care for the individual?
So there doesn't have to be a medical, there's not a specific, it seems like a lot of that could be based on developmental or other needs, but based on what you're just describing, it's not
a rare, there's not a requirement for a rare disease, a rare condition, or a specific diagnosis.
So there probably could be many more families, I suspect, that would meet those criteria.
And I'm imagining that there are, depending on your prognosis, there are probably a fair number of families who are at least theoretically eligible, but knowing that there's a 5-year wait list might not go through the application process. So I'm curious, I don't mean to jump ahead in the agenda, Madam Chair, but based on the data we've gotten back from our other states, do we have any idea what the universe of families out there who need services are, if it, in fact, it's considerably greater than, 323?
That wasn't the information we got, but maybe folks from the Rare Disease Council have information on what the total population looks like in the state.
That's one of the things we're probably going to end up working on. There is no data. I think Dr. Kelser will tell you that there's nothing really. That's one of the reasons we don't know the exact number of rare disease patients. For the longest time, we didn't have all the correct coding to identify them. And one of the issues that we're going to be taking up soon will be doing a survey around the state. So we'll be contacting major, hospitals and physicians around the state to see what we can do. But there's nothing right now.
But given that other states that have administered Katie Beckett waivers some other states don't have waiting lists, I assume we can assume, within an order of magnitude, what that population is likely to be if we were to do something along those lines.
Well, I do think it's possible that for a number of the states, because they're TEFRA waivers, they're not allowed to have a waiting list. So if you go down the list, there's a lot of states here that have TEFRA waivers. TEFRA waiver does not allow a waiting list. If you go on it, you go on it. So that would be the reason in some states you're not seeing any of that. And just to go back for a second to that 54,452 amount per person, if in fact we have a lot of families who are on the waiver who are not actually using services right now because they're waiting, that's going to keep that cost lower. So, you know, if you had more complex kids actually being on the waiver, as my daughter did with all of her nursing care and all of her meds and her equipment and everything else that was going on in her life, that was pretty pricey, even under Medicaid. It was cost shared, but it was still, I'm looking at the 54,000 and thinking, I'm sure she spent more of that, and that was 20 years ago. So just keep that in mind.
But to the senator's point, we could certainly follow up with those states that use TEFRA and see what their numbers are like annually. That might be helpful.
So the question so one question is, right, we know we have 323 people who are waiting to get services. We need to, if we were to provide additional funding, we need to cover that. But there's some number that is, in the woodwork that we don't know because they haven't bothered to apply because their child isn't going to presumably live 5 years. The other question that I have is 54,000 is a good estimate for the cost of people who are currently on the program, but I don't know if the acuity of the folks on the waiting list is the same as the acuity of the people participating in the program, or if it's a approximation or not. So, in addition to seeing the numbers from those states that don't have waiting lists, maybe we could also get some sort of comparison on their costs and whether or not, I don't know whether those states have similar services that they're offered to Connecticut or not, but we could maybe try to get a guesstimate of what that population is so we can figure out how best to serve them.
Great point. Before we move too far into that next document, anyone have any additional questions or clarification for the Department of Social Services?
Do folks who are on that waiting list, do they have to do the full? Is there once you're on a waiting list, do you have to do the biannual check-in? Like what kind, do they have to do the full application at the beginning or is it at the end? How does that work exactly?
They don't have to do anything until they're offered a spot. So they get on the wait list and then there's nothing from the Medicaid financial side or the clinical side that happens till the spot's actually offered. So no requirement that they're actually financially eligible at the time, but when they get on the wait list, but only when the spot's offered.
And it also means you don't really know very much about the complexity of the child until such time as that number comes up, which is another issue with the wait list.
I would also add, just having been on the wait list for 4 years now, the lack of contact is actually a little bit strange. Like as the, consumer, you're not clear on whether how far you've moved up, whether you're still on there. Did your name get lost in the circular file? Like there's no, the lack of contact is kind of notable.
Yeah, that's excellent feedback. So what I didn't say in my introduction is I'm new to this position. I've been here since about May of this year, and we have a new Medicaid director as well, Bill Halsey. And we've been talking about the visibility and exposure and transparency in the HCBS space. And we are looking to build dashboards so people can easily log in to a site and say, hey, we're at this application date. This is the likelihood of wait, and this is how many people are being served. We have certainly heard that feedback across multiple domains in the waiver, and really just the access to information and not having to call someone or email someone and just be able to like, hey, where are we at, right? And we are looking to publish that. So that is one of our near-term goals as we kind of develop the new HCBS space at the Department of Social Services since I've been here. So noted, we're working on it.
Great, thank you. Representative Rader.
Thank you. Just to kind of dovetail off of Jennifer's question, because we don't stay in contact necessarily with the families while they're on the wait list, how do we know if they're still living in Connecticut, that their family member still needs these services? What is the kind of catalog, not, I hate that word cataloging, but just it would be really relevant to be staying in contact with these applicants and those on the wait list to know that, because there could be openings that we're just not aware of, or, you know, the wait list could be shifting if, say, 5 of those applicants have moved out of state, but we just aren't checking on that until their spot comes up. So I'm curious if that would be something we could consider or has been considered.
Yeah.
Posing the question.
That's a great suggestion. Again, like we've been very passive with the wait list. We wait for people to reach out to us for us to provide information out. I think that is something that we could think about doing. You know, there's a fine line between wanting to survey families who are just in desperate need of services and us not calling just to say, hey, checking in, are you still here? What's going on? How's the health of your child? So it's been very much if a parent wants to contact us and report a status change. Otherwise, once they're reached on the spot, we call. And we don't really do, like we said, we don't ask them to continually every year make sure or affirm their desire. We're just assuming, given the conditions, that they will need services, and we'll just, when we reach them, go through the formalities of are you still in Connecticut? What is the situation of the family? Are you able, you know, and some families may have at that time, either through loss of employment or change in status, may have gotten on Medicaid and don't need the waiver. And then that child, you know, would come off the waiver wait list because they've already been served under the state plan. So there's any number of circumstances. We don't typically do a reach out, but we could, again, if we have a more public facing dashboard where people can self-report information or share updates, that we could look into that. That's a good suggestion.
All right, anyone else for the Department of Social Services? And if it is okay with you, we'll take you up on that offer. I'm sure questions will come up as we're meeting, and so it'd be great if we can reach out to you for further information. Does that sound good?
Absolutely.
Wonderful. Thank you very much. All right, so moving to the next piece of our agenda is a document we received from the Council of State Governments, which, for those who might not be aware, the Council of State Governments is a nonpartisan organization that works with legislatures across the country, and they have staff who focus on Medicaid. And so reached out to them again with particular questions. So if there's additional things we'd want to know, we could follow up. They could also be available to present via Zoom. I don't know how best to go through this. I don't know if we want to pull it up or if folks were able to look at it and want to, you know, raise any of the issues or concerns or things that they found interesting. What I had asked and what we were particularly interested in at the start was better understanding the difference between the states that used a waiver or the TEFRA option. How many states had the waiting list? You'll see the subtopics. Also looking to better understand sliding scale and do any states provide different amounts of money to families based on income, which connects back to this conversation we were just having about the fact that some families are currently on the waiver but not using it, because we heard at the public hearing that families might need assistance with just a particular type of service, and so was wondering if, you know, other states do that and allow folks kind of to be able to use it for particular services. Also asked about, do states limit the types of healthcare they'll cover or provide a lump sum for the healthcare costs? Asked if any states have families submit costs and reimburse them based on those costs up to a certain limit. And then if any states tier their illnesses or prioritize them based on life expectancy. And so that's what you're going to see answered to those questions. Because I'm not there and I am notoriously bad with names anyway, for the woman who mentioned she was in Connecticut at the start of the waiver. Do you have any institutional knowledge on why we went the way we went here in our state?
It's Molly Cole. Hi.
Thank you.
Yes, so when we were exploring doing the waiver in Connecticut, it was really an unknown. Remember, there was no Google at the time. So for me to find Julie Beckett in Iowa, I had to go through Senator Weiker's office and ask them to track it down, which I did. And it was actually Senator Weiker's office that helped Connecticut put together that first waiver in the state. And we did it with only 50 slots. And oddly enough, the 50 slots didn't get filled for quite a while because Connecticut was charging families a legally liable relative contribution, which was substantial. So I was paying child support for a child who lived in my home and that I was taking care of. It was a very odd situation. Anyway, the reason they did it that way was just that it was expeditious to get it done. I think the TEFRA waiver probably offered better options. In my national work, after connecting with Julie Beckett and doing this with other states, the TEFRA process became easier and didn't require the kind of waiting lists that we're experiencing in some of the states now, didn't require attempts at somehow rationing services based on severity because it was just open. And to me, that is the logical way to go. I don't know that that's something Connecticut can consider now, but it would make sense to do that.
Thank you. And in your experience working nationally, are there states that are models to look at?
Well, if you really want to look at New England and close by states, look at Rhode Island. Look at Wisconsin, look at Minnesota. Those are all TEFRA states. They do a great job in serving this population.
Thank you. Thank you very much. Other folks, questions, comments on the document at this point? I know you received it today. And maybe we move into using this document and as people can digest it, having the conversation about how best to utilize our time as a working group, what would be important conversations and potential presentations to have as we move forward.
So I have a question, and I don't know where this fits in the order of things, but noting that some states have a sliding scale, and that Connecticut apparently had one initially, or had some sort of parent contribution when this was first created. If if we were to be able to do that and then expand, I just try to think about what's the main added value to the Katie Beckett waiver program, and is that something that would work for most of the families in the program or not? So I don't know if the folks have thoughts on that, or how we would, if we're not able to answer that question today, how we might be able to answer that question going forward. There's a group of families who are getting services. There are a group of families who are not getting services. Would it be good to have some sort of cost sharing, or does that sort of defeat the purpose of what we're doing?
Well, if you have private insurance and you're doing some of your child's care already, you are doing cost share. And that was my objection to coming back and saying you have to pay a legally liable relative contribution as well, because you're already doing cost share. We're just not looking at it that way. But, I spent a lot of time making sure that all of the available insurance coverage was subrogated to DSS so that they could access her insurance and pay those bills. We took care of some of it ourselves, and we did a lot of the care ourselves, as do most families. So we actually got rid of the legally liable relative clause because I ran into a policy person a number of years after we started the Katie Beckett waiver program at DSS. And we started talking about it. And I made this argument that, we already do the care. We already contribute to the care. And the wonderful gentleman who was in charge of policy at DSS at the time took out, and this will date it, he took out a red pencil and he wrote on the top of the policy, in lieu of financial contributions, we will accept in-kind contributions. And we developed a scale, a list of things that families could do. And that was the end of that. So I think you can make a good argument that the cost share is already there. And I do think that for families who are already drowning in costs associated with the care of their child, some of which you may not ever recognize as medical, but have a significant impact on the life of those families, I think it would be a real deterrent to families seeking this out and trying to take on more cost.
If I could just follow on to that comment concerning costs and families drowning in these costs. In the Duchenne space, clearly one of the largest expenses that we have for our children is home modifications and vehicle modifications. I've seen that really bankrupt families. And Molly mentioned the Minnesota plan earlier. Minnesota actually does allow for some of those home modifications, whereas ours does not. I think there's a limited number of home supplies that are allowed for, like beds and such, but there's nothing concerning modifications, which obviously, especially in our expensive state, can really be quite costly. So I just wanted to add that. I'm not sure if it was something that was evaluated in terms of the state by state document that you produced, but I just wanted to put that on the table.
I just wanted to add real quickly too, I just saw this document this morning for like 2 seconds and I'm just reading through it now. So please forgive me if this question is outlined in here and I missed it. Being already on the Katie Beckett waiver, receiving what I do receive, having a child with a very rare genetic disorder, there's no additional help from any other foundations or anything because we don't get any funding from any other source because there's not a foundation for, there's the Rare Disease and Rare Genetic Disorder Foundation, but there's no foundation for children with pontocerebellar hyperplasia, like there just isn't. So I was just kind of wondering again, switching, if there is even the ability to switch from Medicaid to that other system, the TAFRA, what would the benefits look like? Would they change? Would they improve? Like that would just be something that I would be interested in knowing. Would it help the people on the wait list, get on faster, but would it, you know what I'm saying? Like, that's just something to consider in maybe just thinking about it holistically as a whole, as opposed to just like number crunching and thinking about certain different things.
So to my mind, I don't know. I think DSS is the entity to answer that, but in my head, the only way to do that is to actually submit a new waiver that would be a TEFRA waiver. And I don't even know if that's possible, but then you write into it whatever it is you negotiate to cover. I don't think there's a way to just switch our waiver program.
So how Connecticut is distinguished in these TEFRA states is like a fundamental core of how Medicaid is set up and run in Connecticut. So we can't speak to that right now. That's what we were just discussing. Like who should we bring back to talk to you about that? It is a very, very complex. It's not just like let's add the Katie Beckett waiver. Let's add the TEFRA. It is a physical operation of Medicaid. So we wouldn't just be able to do it. And there is likely a very long history of why we are the type of state we are, which it would be probably a fiscally complex conversation, but we could probably have someone do a high level overview of that for you next time.
That
But
would
it
be
does
great.
explain how like every state does Medicaid differently, right? We all have a different look and feel. We all have a different, even our HCBS services, our state plan services, what we offer, what we don't. It is very state specific and very driven by rules that were made ages ago and kind of dictate how we move forward. So not under the realm of, not being able to be questioned, but it's not something we easily can just do.
Beth, was it? Can I go back to you and your comment about, so your child is receiving the waiver? And could you speak to some of the difficulties you're experiencing now that your child's on the waiver?
So my child's on the waiver now. She's been on it for 3 years. I'm not experiencing any difficulties with her being on the waiver, except nursing services. We've been granted nursing services. There's just not enough nurses to service my daughter. The thing that was hard and challenging is that on paper, she looks like a complete disaster. She's got a very rare genetic disorder, and she's very involved, and her prognosis is poor. So, I mean, she checks off all the requirements for being on the Katie Beckett waiver. We don't get the services we necessarily need because of low nursing or whatever. So I don't think there's I'm not experiencing any issues while being on the waiver. It took us a long time to get onto it. We were number 287 when I applied for her. She was 2 years old. So I'll never forget the number. And then I'll never forget the day that we knew that she was put on. But the problem still stands that I think like there's a bigger problem that needs to be addressed, like talking about, children who are terminal, children with like the poor prognosis on the waiting list. And also, the access, if she lives long enough, she's going to need adaptive equipment for a car. Her bed right now, we're just using a trundle bed, but if she lives long enough, we're going to need an adaptive bed. We've adapted a lot of equipment ourselves. So she's too big for a changing table. So we took a stand-up desk and put a mat on top of it so that we can change her. But these things, again, are out of pocket for us. We're spending a lot of stuff out of pocket. Katie Beckett has been a lifesaver in so many other ways, and we're so thankful for it. But there's still, certain things, like I don't know the mother who was up there before who was saying something, but who was it? Jennifer. But there's going to be things that are coming down the line that are just astronomically expensive that we're going to be ending up paying for, that if you're not on the waiver, you're going to pay out of pocket for things that we paid out of pocket for before we were on the waiver. So, it's great when it works. It's really, really great when it works. I don't know if I answered that question appropriately because I really didn't have any problems.
No, you did. It's just helpful to better understand what the experience is looking like. So thank you. I appreciate that. So I've been taking some notes, but I'd love others to jump in with future meetings. So far, I jotted down that it'd be good to like a further conversation on cost sharing and to better understand. And DSS, I believe you said you'd be able to get us in the financial data on what that already looks like in terms of folks who are on the waiver using private insurance versus the Medicaid, but also a broader conversation on cost sharing done in other states. And that then an additional topic that came to mind as you all were speaking was what supplies and services are covered in our state versus other states to better understand that. DSS mentioned, and I think it would be great to have a conversation about what TEFRA, that model would look like potentially in our state. How would we even do it versus what our current model is, to dive deeper into that. Oh, I see Senator Lesser has raised his hand. Yes, go ahead.
Yeah, so I know there's been a lot of discussion about community first choice as being one of the big things that one of the big services that people access on the Katie Beckett waiver. is there a way to get from DSS information? Is that like 90% of the $54,000? Is that like 90% of the cost? Are there other Medicaid services that are also, I'm just trying to think if there are ways to break apart Medicaid, or I'm just trying to think about what it is that people are actually using Katie Beckett for, to have a better understanding about what our options are.
Sure. So this is Christine Center. I'll take that back. So we'll do kind of a more refined fiscal picture for you on the existing members, the existing utilization, see if some of the anecdotal information we've shared and what it looks like in number form. We can certainly do that. I have two questions. One, the DSS list is long. Are these meetings every 2 weeks, once a month? When is all of this due back? Just Paul and I are two people, but we got a team. We just curious, how often are we meeting with this group?
Did we schedule our next meeting, Chandra? What were we thinking?
We have not yet. My understanding that it was going to be monthly, but I defer to you and Senator Lesser.
When I heard that long list of questions and I heard Representative Gilchrist say, "What were we thinking?" I was just thinking, "What were we thinking?" There's a lot of questions we have to answer. Monthly would allow what, 2 more meetings before the start of the session? That's not a ton. 2 or 3. Should we?
Oh, see, Representative Rader wants to join in with this. Yes.
I agree. Like once a month might be cutting it really close with holidays and things like that. So I'm just suggesting doesn't have to be like rigid every 2 weeks, but maybe it's 3 weeks. And then as we start to see things develop, but the other quick question I had was regarding services covered. And Jennifer, you mentioned this, and the other mom mentioned this, is that, modifications to the home. And I'm just curious if we can get clarification on what home modifications are covered on the waiver and what aren't. Like ramps, widening doorways, that kind of, I'm just curious what is, and yeah, and you're shaking your head. No. I would just, if we could just better understand what, if any, home modifications are covered.
So sure. So the waiver itself doesn't have a home modification or a vehicle adaptation additional waiver service. Durable medical equipment, such as lifts, even maybe modified, I don't know, it all depends on how PT and OT writes up the orders, but durable medical equipment is a state plan benefit under Medicaid. So with the proper justification and utilization review, those things are provided. If an individual is on accessing community first choice, which is an additional benefit under the state plan, there are home modification dollars available under that specific program, but you need to be active in addition to just being on having state plan services, which would be the home health benefit. You would be utilizing community first choice, which has a home modification component. But again, has a number of rules and regulations around it on how to access it. So there's no discrete waiver service for home modifications. There is access to home modifications through other state plan options.
And just to sort of underscore what a miss that is, or what a gap that is, I should say, there's going to come a point where my son can no longer take the stairs, right? So we're going to need to install an elevator, or some people might choose to, create a bedroom on the first floor of their home. In most homes, you can't just plunk an elevator in the middle of the house. It doesn't work like that. So at our former home that we lived in until last year, it would have cost upward of $750,000 to $1 million to reorient our home to allow for an elevator. So we made the decision to move instead to a home that will still require a pretty significant investment in an elevator and the structure around it, but is more amenable to something like that. So this is not chump change. This is like a lot of money that families, and additionally vehicles, my understanding, I haven't looked into it yet, but wheelchair accessible vehicles are upwards of $75,000. So just creating some context there.
Yeah, I appreciate that as well. We're going through the same thing. My daughter can no longer walk independently. We've changed our vehicles. We tried to get a stair lift, but because of the angle of our stairs, no company will do it. So we're just carrying her up and down everywhere, which is harder for my spouse. And I think the home modifications has just it's been a challenge, to say the least. A lot of it has basically ended up being in my hands to tear out an island of her kitchen so we can move our daughter around in her wheelchair. Like, there's just so much a parent can do while also being up much of the night because of seizures and other things. So I just want to stress that we explore that further. The other clarification that I was hoping to get, I think I heard that community first choice, you had to apply for that as well. Is that correct? Like, after you get the Katie Beckett waiver, do you have to then take the additional step to apply for CFC? And if so, what does that timeline process typically look like?
Yeah, so we're again in my short term here. We are cleaning up that process for the individuals on the Katie Beckett waiver. So you already are on services. But you're, again, as we described, it's a unique waiver service. You don't have monthly case management. You don't have a total plan of care other than having access to Medicaid. So a community first choice application would be required. We could talk about if we needed to expedite that application to get services in place. Community first choice is also going to be daunting on parents, right? So it's not an easy program. It is self-directed personal care attendance where you are the employer of record. You need to manage your staff, you need to hire them, you need to train them, and you need to make sure that you have staff that are able to provide care for your child. Hours are based on need and medical necessity. And then you will be managing the timesheets, the payroll, and the support of that staff. It could work for some if you have a large village, if you have a network of people that can support you, but again, not always an option for some families, but it is something that is available. So we have a nurse at the department that oversees our Katie Beckett caseload, name's Jan. And we could talk about if there is a family who wasn't aware that they could access CFC, but wanted to consider it and talk to a clinician about it. We could talk to you about, what that looks like to develop a plan of care. But it is a state plan and it is available if that is something that families want to take on. But as you said, it's one more thing to take on. It is a lot of work.
I'm just going to chime in real quickly. I just learned about it 3 months ago. I just had an interview for Community First Choice on the spot 2 weeks ago, and they gave me my allotted hours, which was really nice. I was told there's a 6-month waiting period for the nurse to review the application, even though I was told I'd have a certain amount of hours to work with. But like you said, I'm now going to be in charge of finding people, training people, making sure they report their hours. And while it sounds like a very good program to have, and it sounds like it would be very beneficial to have somebody come into my house and sit with my daughter to make sure that they can suction her and change her diaper and feed her through her G-tube, make sure she doesn't have a seizure, right? I have to do all the background work for that. So it's a really good program in theory. And I'm glad that we do have this. But again, it's something that if you want to take on yourself, it's got to be. But I didn't know about this. So again, my whole point was to say, I've been on the Katie Beckett waiver for 4 years, and I had no idea this existed until 6 months ago. So again, that's about knowledge and getting more information out about the program, what the program can offer. The home modifications, I had no idea that there was no room for home modifications on the Katie Beckett waiver, which is something that I'm going to need because I have a 9-year-old who's spastic and is dead weight, can't move, can't do anything. We have stairs. I have to bathe her. I have to carry her. My husband and I, and we're not young. So that's also things that are interesting that it's all being brought to light here now. I mean, I've learned so much already. I'm in awe, but it's just all of these things that are so important that haven't been talked about and people don't know about until you actually dive deeper into this. So I appreciate your work on getting that out there. I know you've only been here for a couple of months, and I'm sure this is quite eye-opening for you as well, but
it's a complex patchwork, right? So HCBS is not just one thing, right? It's natural supports, it's family, it's state services, it's federal interventions, it's grants, it's loans, it's whatever you need it to be, right? But it's not easy. And we certainly acknowledge it's not easy to navigate. We are trying to make things more transparent and more forthcoming for families. Medicaid is not usually in the business of advertising Medicaid, but it's certainly important for you guys to be as successful as possible, right? So we want to offer that. Like I said, my contact information is there. If you pose questions or if you want to filter questions on behalf of others, please do so. It is a very complex system. Medicaid in general is complex, and then you add on the layer of the complex conditions of these children and the family dynamics. We certainly can appreciate that. I know, Leslie, I know your team reaches out. I'm not always the fastest responder, but I certainly try. And it's not always a good answer, but at least you can get an answer. And we're certainly welcome to listen to ideas about waiver services, and everything just comes with a dollar amount, right? So if we start making Katie Beckett Waiver have a menu of waiver services like other programs, then that comes with a cost, right? A per person cost. And if we're talking about, do we add more waivers? So say Senator Lesser magically finds Medicaid dollars for us for Katie Beckett. Do we expand waiver services or do we expand access? And that was, I think, Leslie, your point. Do we serve more with less, or do we serve more services for the few that already have access? And that is a very hard conversation. And Nick spent his life at DSS answering that by the dollar amount, right? So, but we're happy to hear the suggestions, and we will pose things to our Appropriations Committee and the Human Service Committee and OPM.
Thank you for this conversation. It's been really, just really enjoyed it. And I think in terms of the money and the cost expenditures, I'm curious, like with the Katie Beckett waiver program, what is the percentage cost of that program in comparison to the full Medicaid budget, or in comparison to like other waiver programs?
That will be a come back with you with a number.
Thank you.
Great question. Okay, so we've got some great ideas for future meetings. It's looking like 3 weeks would be good versus a full month, so we can get in some additional meetings. Are folks available on Monday, October 21st? Would 1 to 2:30 work, or should we stick with this time? I can't see folks' heads in the room. Does Monday the 21st work?
That works for me.
Folks online? 1 o'clock on Monday, October 21st?
Works for me.
That works for us.
All right, wonderful. So please hold that. What the senator and I will do is we will go back and take these notes that we've accumulated today and connect also with DSS to see what information they'll be able to get to us by that next meeting to develop an agenda to address. Again, we won't address all the topics, but start on some of these topics at the next meeting. Does that sound good to folks?
Sure.
Yes.
Wonderful. Wonderful. Well, there is just such a wealth of knowledge around the table, and I really appreciate getting to learn from you all. Any final questions or comments before we wrap up today?
Well, here's just one more Medicaid question, Christine. I'm sorry to add to your list, but here's a thought. Because we have a waiting list and we don't really know the level of care of any of those individuals, is there a way to give a cost estimate of what it would cost to pre-screen those folks when they call? So, because I will tell you, I've talked to families who have said, well, I want to apply for a Katie Beckett waiver because, we might need a home health aide sometime in the future. And I'm like, well, do you need it now? No, I don't need it now. So I think there's a need to really take a closer look at who's being driven onto that program. And sometimes it's a basic misunderstanding of what they would actually have covered in that service. So I don't know if there's a way to do that, but it might be worth looking at what the cost might be to do it.
That's certainly something I could take back. I know we do an application. I'm not sure the robustness of what's included on that and if it could be done passively or if it would take a call. Again, we're very sensitive to calling families without news. But we could look and we can talk to our clinical team who speaks to these families day in and day out and see if she could give us a better understanding.
That sounds great. That's also, I think, something as, and I'm gonna take this on with folks, reaching out to these other states. I think it'd be interesting to know what they're doing in terms of that.
Rep. Gilkert, can I just confirm, is the expectation that DSS is doing the inventory of other states, or is someone else collecting that information? I just want to know if that's on us as well.
That is not on you.
Okay.
That'll be on, yes.
Thank you.
You can focus on
sure
your
Paul will
department.
start calling. Yeah. I got Paul. He'll start calling. I just wanted to make sure that wasn't a DSS to do.
Yep. Nope. Not on you. All right. Well, thank you all for a very, this was a very effective first meeting. So really appreciate it. And look forward to seeing you all again on the 21st. Thank you.
Thank
Have
you.
a great afternoon.
Thank you, everyone.